The final formal speaker this morning will be John Watkinson, and he'll be talking about indications and extent of lateral neck dissection. John, please. Thank you.
Well, good morning, ladies and gentlemen. What a privilege and a pleasure it is to address this panel at this distinguished conference. I come to you from the United Kingdom. I have nothing to declare or disclose except to express my thanks and my admiration for this gentleman for putting on a wonderful meeting, for a lifetime of advice to the fellows and the workers in the United Kingdom, and personally his mentorship to me over the last 30 years. I'm here to talk to you about lateral neck dissection and differentiated thyroid cancer. What I wanted to discuss is the extent of surgery, which incision you might want to use, how the complications might relate to the publication of outcomes that we've just heard about when we come on to surgeon outcomes, and then discuss the levels of evidence. The weakest evidence of all is, of course, me standing up here talking to you, but there are two very distinguished systematic reviews in the literature, the revised ATA guidelines in 2009, and then the British guidelines that were published a month ago. That's the third edition of our guidelines. So between the two guidelines, I think if you go and read those, you have a very good source of levels of evidence about what to do in differentiated thyroid cancer. When am I going to operate in the neck in differentiated thyroid cancer? When I strongly suspect, or I definitely know that there's cancer, when I'm dealing with recurrent disease, and as we've just heard, when you're operating on the neck for lateral neck disease, you may want to do a central compartment neck dissection as well, and vice versa. When you've got disease in the central compartment, you may want to think about a prophylactic lateral neck dissection of one level or another. Can I just make some general comments to this room? There is usually no role for a prophylactic neck dissection in the lateral compartment based on the literature. There is no role in the untreated neck to go into one level and start berry picking. Selective neck dissection is based on the natural drainage of lymph nodes in the neck, which has a recognized pattern, and that's on what we base our selective neck dissection operations. Remembers the corners of consternation. These were mentioned yesterday by Mark Izzard in a video session. That is the edges of your neck. Corner 1 down here, Chassenax triangle. Corner 2, lower end of the triangle. Corner 3, apex of the posterior triangle. And corner 4, levels 1. It's not so important in thyroid as it is in squamous carcinoma, but you need to have the concept that when you're in a zone, you dissect the zone. And the other thing to remember, the more selective you are, the more difficult you might make the operation. What's the extent of the operation you're going to do? Did this patient have a total thyroidectomy half an hour ago, or did it happen 30 years ago? Are you doing this singly or combined? And was it you that went into the neck previously? What levels have you made your mind up to dissect? My advice to you is, once you've made your mind up, dissect those levels and do no more. It's a bit like a rhinoplasty. Do what you set out to do. What incision are you going to use to get access to these areas? And are you a surgeon that's trained to go lateral to medial or medial to lateral? Because the backgrounds of general endocrine surgery and otolaryngology are different sometimes in the techniques of neck dissection. We've heard about the primary echelon nodes really in level 6, level 4, and level 7. And of course, the extension of disease then proceeds into the second echelon nodes that really encounter the lateral neck. That's levels 2, 3, 4, and 5. 100 years ago, when Sloan Kettering began, and nobody really knows when this diagram appeared, but it was probably in the 1930s. But we owe so much to Sloan Kettering for the levels. But these have now been reclassified so that the ones that interest us are really 2, 3, 4, and 5. And the subdivisions 2A and 2B are important. And of course, 5A and 5B are important when you are a thyroid surgeon. And level 6, of course, is very important. I've mentioned the corners of consternation, but the major ones are not so important in thyroid surgery, but the minor ones are. I'll show you these, because when you're revising a neck, you need to understand that disease is in the parapharyngeal space, sometimes the retropharyngeal space. But the one area that you must concentrate on is Chassenac's triangle. This is the area at the lower neck. It's the key to the neck. It's where scalenus anterior joins longus colli, and it's the area that lies behind the internal jugular vein and the sternomastoid muscle. If you've taken those structures, you're straight onto it. But this is where you get neck recurrence. This is where you get scalene nodes. This is where you get lower level neck nodes. So you've got to go behind the jugular vein, and some people do it coming medially, particularly in France, and dissect level 4 behind and over the jug. But this is crucial to thyroid surgery in the primary setting. So what do people say around the world? Our American colleagues recognize the incidence, which is high, of neck nodes in levels 2, 3, 4, and 5. And I draw your attention to what's already been mentioned before, is the advice is a functional compartmental en bloc resection. Now, there is no mention to levels here. What I suggest you do, that you remember there's a poetic license to thyroid surgery. What this doesn't mean is level 2 and 5. It doesn't mean level 6 and 2. I think it means you do 2, 3, and 4, and depending on what you need, you might want to add 5, bearing in mind 5 adds a lot on to your operation, particularly if you're a surgeon that goes medial to lateral, not lateral to medial. There you have it, the recommendations from the ATA. You do an operation which is not a berry-picking operation, so it's more than one level. The levels are up to you following your MDT discussion. Recommendation level, not that high, but it's not just expert opinion. What about those of us in Great Britain? What do we recommend? Well, first of all, we recognize that if you've got disease in the lateral compartment, you're likely to have disease in the central compartment as well. So when you're doing a neck dissection with a total thyroidectomy, you do a central compartment dissection. Bang. When you go into the lateral neck, you're going to dissect the zones that you want to dissect, and that is, we recommend 2A to 5B, bearing in mind, again, there's poetic license to do 2, 3, and 4, and leave 5 for another day and follow the patient up with serum thyroglobulin measurements. We do not recommend that you routinely dissect 5A, 2B, or 1. This is what I've just said about prophylactic neck dissection. We've heard presentations already in this conference about prophylactic lateral neck dissection. I don't do it, but you can argue on an individual basis that if you've got a lot of disease in the central compartment, you may wish to go and dissect level 4. This is very popular in France as a routine thing, and do a prophylactic lateral compartment neck dissection of 1 or 2 levels. But most people in this room will not be doing a prophylactic lateral neck dissection of levels 2, 3, 4, and 5. What does this mean? Many of you will have seen this slide, but when you look at the thyroid and the central compartment, you're going to dissect that zone, preserve the nerves, you're going to find that accessory nerve, you're going to stay medial to it, you're going to dissect 2, 3, and 4, and maybe go into 5. Some people take the thymus as well in level 7, routinely in papillary. There's no evidence you have to do that. That is an individual decision for you. How are you going to get there? I suggest you use a traditional coca, which can be extended. If you need to go posteriorly in the neck, then you extend it laterally, the thyroid utility incision, or a very popular incision in the slimmer patient is the mid-neck cross incision. Jay Shah likes that, and you can get up and down the neck easily using a midline coca modified incision. Like fine wine, your scars will mature. You put your scars in the right place, they're fine. But you put a thyroid scar in the wrong place, at the wrong time, in the wrong position on a neck, it'll come back to haunt you every time you see that patient. Because these patients live a long time, and you'll be seeing this patient at every follow-up, and you'll be looking at her neck. Not everything in life is easy. So some necks are easy, and some necks are difficult. They're difficult to assess, they're difficult to operate on because the disease is big, it's angry, it's extensive, it's in the chest, you've got difficult histology. But for this purpose of this talk, you can have recurrent disease. I always restage the recurrence. And were you the person that did the initial operation, or is this person being sent to you by somebody else? The basis of selective neck dissection is gone, so local excision may prevail and berry picking may be allowed. The recommendation of our American colleagues suggests now that if you've got extensive disease, you should be doing a comprehensive, which I take to mean a level 1 to 5 dissection, should it be indicated. However, with previous treatment, previous levels dissected, you may wish to do something less, which is in essence is berry picking. In Great Britain, we agree. Surgery is the treatment for thyroid cancer, for recurrent thyroid cancer and recurrent thyroid cancer in the neck. We haven't said the levels here, but we agree that you go and do a comprehensive dissection of the levels that are involved. We recommend that for low volume disease, you may want to monitor these people and follow them up rather than reoperate. If you've got residual disease, you might want to give them I-131, and if that's not appropriate, external beam. And for those patients with distant metastases where neck disease is a problem affecting the airway, you may have to operate for palliative care. In the final few minutes, I'll just put up the first 2 pages of the new British guidelines because it's relevant to what's been said in the previous talk. In the United Kingdom, through government, it's now been stated that if you operate on a thyroid, you should have the training and expertise in the management of thyroid cancer, and you should discuss the patient at a team meeting. If you want to operate on one thyroid cancer, you should be doing 20 thyroidectomies a year. If you want to operate on lymph nodes in thyroid cancer, you will be nominated by your team, and your data should be submitted to the now mandatory national audit, which we hold in all hospitals on anybody doing thyroid surgery. Oh, sorry. What does that mean for me as I stand here? Well, if you go out of the room in half an hour and you Google my name and you go onto the British Association of Endocrine Surgeon website, you will get the hospital where I work, the number of operations I did in the last 3 years, the length of stay, which some of you will be working out is a surrogate for hypocalcemia, and your return to theatre rate, which is a surrogate for hematoma. Added this year is a 6-month hypocalcemia rate and also data completeness. So we hold a lot of data which we don't publish, and this year we're doing 13 sites in the United Kingdom. Cardiac was the first over 10 years ago, but we're now up to 13 primary sites for publication of surgeon outcomes. So where might we go with lateral neck dissection? The previous slide, again, the people amongst you will have observed that that's actually a surrogate for central neck dissection, isn't it? All the information was there. For lateral neck dissection, we already hold your name, the hospital where you work, the number of cases you do, and the levels dissected. We have your return to theatre rate and your infection rate, and if you add the accessory nerve complication rate, you have everything you need for outcomes for lateral neck dissection. I put the recurrent laryngeal nerve up there because it was missing for the primary site, and that's because input for pre and post-op vocal post-op vocal cord examination rates are incomplete in the United Kingdom for lots of reasons, but we are correcting that in the future. So, ladies and gentlemen, what a privilege it's been to address you this morning. What about some tips and tricks in lateral neck dissection that I've learned over many years in thyroid surgery? Keep your options open. have poetic license. Maintain the ability to go medial to lateral and lateral to medial, and don't be afraid to divide the sternomastoid muscle low down if it gives you good access, and then you just simply put it back and resuture it. Level 2B can be a problem. That's Suarez triangle described by Pat Gillane. If you can have problems with recurrence, and if you're in doubt, please dissect it. Don't forget the corners of consternation. Remember that contralateral neck. When in the zone, dissect the zone. So in summary, the treatment of suspected or proven differentiated thyroid cancer in the neck is surgery. The extent of the surgery at the primary site is based on natural drainage and predicted outcomes, and its levels 2, 3, 4, and probably 5 in certain situations. When the disease comes back, the treatment is surgery. The extent of surgery is probably going to be sometimes more extensive for lots of reasons, but again, you sometimes can do a berry picking. Follow it up with adjuvant treatment when required, but I think personally the best results come when you get it right first time. Ladies and gentlemen, thank you for your attention.